Robin is a research midwife specialist at Health New Zealand, Te Watu Ora, counties Manakoa in Auckland, New Zealand, and is involved in a range of local, national, and global research projects. She completed a PhD in late stillbirth risk factors, which has contributed to a change in maternal late pregnancy sleep position in New Zealand, Australia, and the United Kingdom. Robin enjoys working clinically with midwifery students in the birthing suite each week. She's also an honorary lecturer in the Department of Obstetrics and Gynecology at the University of Auckland. Welcome, Dr. Cronin. Just tell me when you're ready to move the slides along, and I'll get them moving as fast as I can.
So thank you very much, Cecilia. So tēnā koutou katoa, ko Robin Cronin toko ingoa, he kahu pokai Aoi Health New Zealand, te whatu ora counties Manukau, Tamaki Makaurau, Aotearoa-New Zealand. So hi everyone, my name's Robin Cronin. As Cecilia said, I'm a research specialist midwife from Auckland, New Zealand, and it's actually a real pleasure to be able to share the findings of our qualitative interview study of diabetes in pregnancy, women's views of care in a multi-ethnic, low socioeconomic population with midwifery continuity of care. Next slide, please. It's reluctant to show up, but
Yeah.
there it is. So for those not familiar with New Zealand, our beautiful country is at the bottom of the globe. Next slide, please. Or, as we like to think of it, at the top of the globe. So a couple of fun facts. So Aotearoa-New Zealand is near the centre of the world's water hemisphere, which means it contains the Earth's largest possible total area of ocean. And we're the 6th largest island country in the world. Next slide, please. It's because it's coming from a long way away. The bottom or the top of the world.
Yeah. In the last session, I turned my camera off to save bandwidth. With this view, I can't, but I'm wondering, Paula and Ernie, if you can turn your cameras off.
Oh. Here we go.
There we go. That might help.
So the two largest islands that make up Aotearoa-New Zealand, that's okay, I'll keep going, are rather unimaginatively named the North Island and the South Island. But more importantly, they're also known by their Māori names, Te Ika Maui, or Fish of Maui, so it's the next slide after that one, or Te Waipounamu, the Waters of Greenstone. Here we go. And the North Island has over 4 million residents, and the South Island has just over 1 million. And the research that I'm presenting today was undertaken in the Te Whatu Ora Health New Zealand Counties Manukau district of Auckland, which you can see right up the top of the North Island, or Te Ika Maui. Next slide, please. So Auckland's Māori name is Tamaki Makaurau, which also means Tamaki of 100 lovers. And that's due to Māori who arrived here around 1350, admiring the desirability of the natural resources of the region. A subtropical climate, very fertile land, 53 dormant volcanic cones, and one of the volcanic cones is in the foreground there with beautiful views over Tamaki Makaurau, and 2 harbours. Although the increasing birth rate in Auckland, which is by far the largest city in New Zealand, also indicates that indeed there are plenty of lovers living in the region. Next slide, please. So the Counties Manukau region is in the pink colour and it's in South Auckland, and we serve the largest birthing population in Aotearoa, New Zealand, with around 8,000 births every year. Next slide, please. And here are a few photos of our fabulous midwives and doctors, and a bit of a recap on the New Zealand maternity care system. So all maternity care in New Zealand is free from conception to 6 weeks after the birth, and women can choose to have their maternity care from a midwife or from a doctor in their own homes and community-based antenatal clinics, midwifery-led birthing units, or in hospitals. And care can be transferred or shared to hospital specialists if there are any complications during or after the pregnancy. And in Counties Manukau, we have 4 midwifery-led low-risk birthing units and Middlemore Hospital, which you can see in the photo there, which provides care for women and babies with higher risk, including those women with diabetes in pregnancy. Next slide, please. And here are photos of 3 of our beautiful mothers and babies from our annual maternity report. And Counties Manukau is privileged to have the largest Pacific population in the country, including Samoan, Tongan, and Cook Island Māori women. We also have the second largest Māori population in New Zealand and 1/5 of New Zealand's Asian population, primarily people of Indian and Chinese ethnicity. Next slide, please. So back to diabetes and pregnancy. So diabetes in pregnancy affects around 1/6 of pregnancies annually in our country. It's now the most common medical complication of pregnancy, both nationally and globally. And we know that the risk factors for diabetes in pregnancy, including having a BMI in the obese range, advanced maternal age, polycystic ovarian syndrome, and a personal or a family history of diabetes. And diabetes disproportionately affects Pacific, Māori, and Asian mothers. And Pacific and Māori women with diabetes in pregnancy are more likely to require insulin, to develop preeclampsia, and to give birth to a large baby compared to women of other ethnic groups. Next slide, please. So, as mentioned, we have around 8,000 births annually, and our mothers are predominantly non European. Nearly half have a BMI in the obese category, and 2/3 live in neighbourhoods with the highest level of deprivation. So, it's not surprising that the rates of diabetes in pregnancy in the Counties Manukau region have more than quadrupled over the last few years. Next slide, please. We also know that pregnant women with poorly controlled blood glucose levels have an increased risk of pregnancy complications, including high blood pressure, preterm birth, and giving birth to a large baby. And their newborn babies are more likely to be diagnosed with a low blood sugar and respiratory distress. And long-term adverse metabolic outcomes for these women include up to a 60% increased risk of type 2 diabetes, 45% increased risk of cardio and cerebrovascular diseases such as heart disease and stroke, and a 28% increased risk of thromboembolism. And their babies face a future risk of obesity and type 2 diabetes. Therefore, timely diagnosis and management of diabetes in pregnancy to normalize blood glucose levels can reduce harm and improve health outcomes for these mothers and babies. Next slide, please. So in the Counties Manukau region, women with diabetes in pregnancy receive care from a multidisciplinary team, including specialist diabetes midwives. And this care has traditionally been face-to-face in busy hospital outpatient clinics, where long waits and limited time spent with the doctors and the midwives is the norm. And at the onset of the COVID-19 pandemic, it seems a long time ago now, but just in 2020, Counties Manukau commenced telephone clinics or teleclinics for women with diabetes and pregnancy, supported by the international evidence that this may increase access and engagement with care and reduce the need for face-to-face clinic visits without compromising outcomes for the mothers and their babies. However, there is very little information on the views of women with diabetes and pregnancy about their pregnancy care from a multi-ethnic, low socioeconomic population within the model of midwifery continuity of care, and none in relation to teleclinics for this population. Next slide, please. So our aim was to find out what women thought about their care. The participants were women who had had care from our diabetes service and who'd given birth relatively recently and who had agreed to have their contact details entered into our county's diabetes registry, and to be invited to take part in any future research. And as most women with diabetes in our region are of Māori and Pacific ethnicity, with an increasing Asian population, it was considered critical to have the women from these ethnic groups represented in our research. And our methods, well, as we went into a second prolonged COVID-19 lockdown at the time of recruitment, instead of our planned focus groups, we had to switch quickly to semi-structured telephone interviews. And the interviewers were matched by ethnicity with the interviewees. And data was analysed using thematic framework analysis, which loosely means that we developed themes from the women's interviews deductively, so using evidence from the literature, and inductively from the woman's transcribed interviews. Next slide, please. So how did it go? Well, we interviewed 19 women based on our 4 main ethnic groups. 4 had pre-existing diabetes and 14 had gestational diabetes diagnosed in pregnancy. We had slightly more mothers who'd had babies before than we did first-time mothers, and their babies were 6 to 15 months old. And gestation at birth was 38 weeks for all, and that's related to our policy of induction of labour at 38 weeks for women with diabetes and pregnancy. And that's because the large majority have comorbidities, such as a baby large for dates over the 90th centile, suboptimal blood sugar control, or things like reduced fetal movements. Next slide, please. So analysis of data identified 3 key themes: shock, shame and adjustment, learning to manage diabetes in pregnancy, and preparation for birth and beyond. Next slide, please. So we're going to take a look at shock, shame and adjustment in more depth. Next slide, please. So diagnosis of diabetes in pregnancy was accompanied by shock and emotional distress for all participants, and that was regardless of their ethnicity, parity, and previous experience of diabetes, although those diagnosed for the first time had much stronger reactions. One Pacifica mother said, "I would have liked to have been given more time to tāla noa, to talk about it, and be reassured that the whole world wasn't coming down on me and baby." Another said, after being given the diagnosis, "I was too emotional. You need more time to just sit there and to ask the questions, silly or not." Most women had received their diagnosis in person, but a few by telehealth. So that was text or phone call, followed up by a video call or a face-to-face clinic appointment. All emphasised that being physically present with a healthcare professional for their diagnosis was important and helped make the diagnosis feel real. Next slide, please. There was also confusion around the implications of diagnosis. For those who professed a healthy diet and lifestyle, there was complete bewilderment as to how they could have developed diabetes in pregnancy. As this Fiji Indian participant said, "I thought I was quite healthy, but when you think of diabetes, you think of just junk food. I just didn't understand. I was really, really shocked." And participants who were recent interviews wondered if the change in access to traditional foods since arriving in New Zealand had participated or precipitated their diagnosis. Others with older family members with type 2 diabetes worried that diabetes in pregnancy may also be a lifelong condition. One mother expressed her confusion by saying, "I knew it was an issue with sugar, but I thought it meant I'd have it forever like family members, or that after pregnancy it would just kind of continue." Next slide, please. Previous research has reported that diagnosis of diabetes in pregnancy can lead to stigma, with women feeling guilt, sometimes coupled with reproach from other healthcare professionals, from family, or from community, mainly around their weight. This Pacifica participant, who had 3 pregnancies complicated by gestational diabetes, explained, "One of the major things is just removing the stigma by just making people more aware of it and the causes, because otherwise they'll just ignore the screening or they'll hide it. And really, you have nothing to be ashamed about." And many of our participants reported self blame. My heart went out to the woman who told us, "I felt quite overwhelmed and disappointed in myself that I could have made better choices, but I simply didn't. And it put me and my baby both in a vulnerable space." Next slide, please. Now, support from healthcare professionals, in particular midwives, assisted women's adjustment to their diabetes and pregnancy diagnosis, with the woman describing how midwives' explanations and support helped them reframe their diagnosis as an opportunity to manage their pregnancy. This woman said, "It's helpful to know that it's not the end of the world, that there's still things you can do to have a healthy pregnancy, being more disciplined and more tōkanga, careful with your pregnancy." And the support and advice motivated some women towards a healthier lifestyle that continued after the pregnancy. As this mother described, "I realized that I could still make a difference if I took up healthier decisions and medications, that it would turn out okay in the long run." Next slide, please. So, our second theme was learning to manage diabetes in pregnancy. And I'm going to talk more about that in the next slide, please. So, this included most participants describing midwifery support as the backbone of their care, aligning with high level evidence on the advantages of midwifery continuity of care, including a brand new Cochrane review that's just been published, and a 2023 review that identified that at risk in multi ethnic populations and high income countries, that for them, midwifery models of care may improve women's engagement with their health care. And it was nicely illustrated by this participant who talked about the value to her of having both a diabetes specialist midwife and a continuity of care midwife, saying, "I had a diabetes midwife. She was the main port of call for her diabetes, plus her normal continuity of care midwife, and that helped a lot too." Another mother who'd had a complicated pregnancy said, "I had my own midwife, which was her continuity of care midwife, and I loved her to bits. She knows me and she can be very convincing, like telling me to get to the hospital because something serious might happen." Next slide, please. Women also felt that having a healthcare professional who understood their cultural background would have enhanced their engagement with care. Some expressed frustration that the type of foods recommended to help manage their blood sugars were often foods they did not have access to, reporting there seemed to be little understanding of non European cultural perspectives on food. And the top quote shows this Pacifica woman's frustration with that, saying to us, because when somebody in the diabetes service had said to her, "You need to not eat rice," I'm like, "Do you even understand what you were saying?" And similar to previous research on migrant and indigenous women's views of care, our Maori, Pacific, and Asian participants would have liked more culturally specific resources to take home and to share with their families, as well as information and care in their first language, ideally from staff of the same ethnicity. And this participant's quote nicely sums it up, saying, I feel like if I would have seen a Māori nurse or a Pacifica nurse, then I would have felt somewhat more comfortable. It would help people, especially our people, to feel comfortable. And information specific to diabetes and pregnancy in Aotearoa was prized by all our participants, and all wanted more. Next slide, please. And women also suggested that having a variety of forms and ways to access diabetes and pregnancy information would have improved their understanding, saying that it would have been helpful to receive resources in a range of formats to suit different women. This woman saying, and I really liked her honesty, if I was to take a pamphlet, the chances of me actually reading it or even getting time to read it, well, they're pretty slim. The information I got from my midwife was enough. Other women preferred information supported by visual images. Like the mother who said that the conversation from a nutritionalist was hard to understand because she was more like a picture person. That if you just showed me and have diagrams, it would have helped her get her head around the conversation. And many said they would have liked better access to online resources such as chat groups, videos, or web pages. And in fact, almost all had Googled diabetes and pregnancy, most not finding the information that they wanted. Next slide, please. So most women said they preferred a hybrid of in-person and teleclinics for their care from the diabetes service. And teleclinic phone calls, especially with a known diabetes specialist midwife, were reported by the women, especially Indian participants, to remove many of the barriers to in-person appointments, such as childcare, transport, parking, and time off work. And we've all seen the long waits and busy antenatal clinics, which were illustrated by this participant's words. They've forgotten that I've arrived. I've sat here for over an hour, and other people have left before me who came after me. However, Māori and Pacific women in particular, while appreciating the convenience of the teleclinics, reported that having the option of face-to-face care was important for relationship building between them and the healthcare professionals. And as this participant explained, I engage more and I feel like the health professionals engage more when you are face-to-face. There's more tauiwa or nurturing relationships. And all women were unequivocal that in-person consultations were superior for their understanding and emotional support, not only at first diagnosis of diabetes and pregnancy, but also when some potentially distressing or complex information was being provided, such as when needing to commence insulin. Next slide, please. So our final key theme was another area where many felt care could have been better, and that was preparation for birth and beyond. Next slide, please. With lack of understanding or lack of shared decision making for timing of birth. And while women were generally positive about their care providers, most reported they were not given choices around timing of birth, but rather were informed they'd be induced on a certain date. One telling us that she was advised, look, when you get to hospital, they'll tell you what to do. Another said, the way that they say it, it seems like you're going for a walk in the park, but when you're actually at the hospital, it's literally like you're running through a forest trying to find your way out. And some had no recall of any discussion of the rationale for induction or any consideration of their personal circumstances or their views. Next slide, please. And most described insufficient preparation for labour and birth, and many felt completely unprepared for the invasiveness of procedures such as vaginal examinations, IV insertion, and the level of pain. And the quote about the forest you can see is repeated here because it shows how unprepared this woman felt. Another woman told us that the experience of induction interventions and the pain was really traumatizing, saying, I went through an induction and I came out quite traumatized. And she had to get therapy for her trauma after the birth. And actually reading her transcript was really, really heartbreaking. Next slide, please. And many also reported poor communication around newborn blood sugar testing, being largely unaware that their baby would require repeated heel prick blood tests to monitor for hypoglycemia following the birth. And seeing their baby cry in pain at the heel pricks was distressing for many women, especially as some felt responsible and felt guilt for their baby's pain through having been diagnosed with diabetes in pregnancy. And another woman I felt really sorry for was this one who told us, "My son got samples taken from his foot. I didn't know it was going to happen. I kept saying, 'Is that enough?' I started getting quite angry, and so did my husband. I just felt sorry. It's not his fault. I think I could have prevented it, but I didn't." And others misunderstood the reason for their newborn blood sugar testing, like this woman who thought that their baby's heel prick blood test was to see if her baby had diabetes. So you can see there's a lot of work we need to do there. Next slide, please. Following the birth, participants were surprised at the sudden termination of support from the diabetes service on admission to hospital for the birth, and several women felt abandoned. Some were under the impression that the abrupt loss of input by the diabetes service meant that their diabetes was no longer important, illustrated by the words, "The baby is out, so you're done." Few had clear understanding of the recommendation for postpartum type 2 diabetes screening to reduce future health risks. Yet, as we know, postpartum screening supports a reduction in type 2 diabetes, heart disease, stroke, and venous thromboembolism for these women. And the multi ethnic population of women who have experienced diabetes and the postpartum follow up for these women is absolutely vital if we want to work towards our aim of health equity. Next slide, please. Now, a major strength of this study is that it fills the identified gap in knowledge of midwifery-led continuity of care model of diabetes and pregnancy care and telehealth care for this population. And the researchers that interviewed the woman were matched with the participants by ethnicity, and they were not known to the woman to help support the expression of the woman's views. And you can see that the woman had both positive and negative views that she captured. The limitations of this study were fairly typical for qualitative interview research with small numbers, self report, and a convenient sample. And as the data was collected August September 2022 in Auckland, New Zealand, most women had at least part of their care during a COVID-19 lockdown, which was a hard lockdown with women not able to leave their properties, and that may have affected their views. Next slide, please. So, finally, in summary, for this multi ethnic, low socioeconomic population of women in a model of care delivery that includes telehealth, face to face consultation continued to be beneficial, especially for diabetes and pregnancy diagnosis, and especially for women of Māori and Pacific ethnicity. And the women expressed that culturally appropriate resources in their preferred language that included traditional foods was desired but lacking, while information around birth expectations and the importance of postpartum diabetes follow up was also limited. But a unique finding was that an ongoing relationship with a consistent diabetes specialist midwife alongside a community based continuity of care midwife was highly valued and supported women's engagement in their care. And the good news is that as a result of this research and other research with women with diabetes and pregnancy in the county's Manukau health region, that there's been a positive change in our service. A booking clerk now attends the diabetes clinics to offer face-to-face and telehealth appointments at a time and date chosen by the woman. A psychologist has been employed to work within the diabetes and pregnancy service to provide free consultations for the woman who is struggling with their diagnosis. And there's been an increase in staff in the diabetes service, including community health workers, to work alongside the diabetes midwives to support them to allow those diabetes specialist midwives more one on one time with the woman. And free mobile phones have been provided with free data so that if women don't have access to their own phone, they're given a phone, and a text message service has been set up to remind the woman when they're around the 3 month after the birth mark, that a form has been sent for a free follow-up blood test for type 2 diabetes to their local laboratory, so that the woman can just present somewhere local and have the blood test. And last slide, please. So finally, ngā mihi nui kia koe, and thank you to the woman who so generously participated in our fabulous diabetes and pregnancy research team, and of course you, our audience. Thank you very much.